Right. So I think it's time. Let's get going.
Yeah, I think so. Well, thank you and welcome to tonight's I3 session, where we fully expect to have a lively discussion and an insightful webinar dedicated to improving communication in fertility care. I'm joined by Andrew Thomson, consultant clinical embryologist who has worked at some of the most successful clinics, such as Oxford Fertility and London Women's Clinic. He co-designed Avenue Centre for Reproductive Care, in London, which is the first clinic to use AI from end to end in its digital infrastructure. He now operates his own consultancy company, IVF Scientific Advisory Service. And Elina Roumian, a senior clinical embryologist and education coordinator at CERT in Australia. She's currently working for IVF Australia in Sydney. It's one of the busiest labs in New South Wales. And for further details on any of the moderators or speakers tonight, you can look on the I3 website, so make sure to check that out. Andrew.
Well, thank you for the introduction, Simon. To introduce himself, he is the VP of Sales at Fertile AI, specializing in fertility technology and medtech innovation, with experience at Lighthouse Fertility, Overture Life, and Vitro Life. Simon's passionate about using AI, genomics, and automation to improve fertility treatment. His work focuses on making fertility care more accessible and efficient through cutting-edge technology. Some of that work that we've talked about over many years in many countries. One of my favorite drinking buddies on the international conference scene. Tonight's session is all about how do you speak to your patients and how do you explain complex issues. So we've got a stellar cast: Sarah Lensen talking about IVF add-ons, Madison Bailey talking about breaking bad news from the trainee's perspective, and Lize Leunens talking about polyparenthood and co-parenting. Elina?
Hi, everyone. It is a pleasure to be here this evening or this morning for us in Australia in what promises to be an enlightening webinar. To remind you, please put your questions on the Q&A section and not the chat function to have your question proposed to the moderators. Our first speaker is Dr. Sarah Lensen, Senior Research Fellow at the University of Melbourne, specializes in women's health, particularly in fertility and IVF. She has led major clinical trials on infertility treatments like intrauterine insemination and endometrial scratching. An editor for Human Reproduction, Fertility and Sterility, and the Cochrane Gynecology and Fertility Group, she has published extensively on evidence-based reproductive medicine. Her research focuses on unproven treatments in reproductive medicine and developing evidence-based resources for informed decision-making. So Sarah, take it away, please.
Thanks, Elina. Hi, everyone. Thanks very much for having me. Today I'm talking about IVF add-ons, hope, hype, and hard evidence. So just quickly, I have a strong research interest in IVF add-ons, and I don't have any financial relationships with any IVF clinics or any commercial companies. All of my research funding comes from university, charitable, or government sources. So while there's no sort of black and white definition for IVF add-ons, we usually think of them as medicines, techniques, or procedures which are in some way additional to what might be considered standard IVF. And they're usually used with the aim or the hope that they're going to increase the chance of success in some way. So this can include things that might happen in the IVF lab, like using embryo glue or doing PGTA. It can include things that the IVF specialists or clinicians might prescribe or perform, procedures like endometrial scratching or intralipid infusions. And it can also include things that happen outside the IVF clinic that patients might access in the community or from other healthcare providers that sometimes the IVF clinic might not even be aware of, like patients seeking out acupuncture or Chinese herbal medicine or nutritional smoothies that they're taking with the hope they boost their chance of success. We also know that these add-ons are pretty widely available. So the top two studies on the slide conducted by our team and some colleagues show that IVF clinic websites in Australia, New Zealand, and the UK often list these add-ons as being available there and market them to people visiting the website. And we also know, based on the 2 studies at the bottom, that the add-ons are widely used. So they're not just widely sort of available and advertised on clinic websites, but a lot of patients are using them. And so in these 2 studies, again, in the UK and in Australia, we found that over 70% of IVF patients have used one or more of these add-ons during their IVF journey. And we also know that most of these add-ons are not supported by sort of robust evidence that they can increase the chance of getting pregnant and having a baby. So I'm an editor for the Cochrane Gynecology and Fertility Group, and we've produced a special collection available on the Cochrane Library where we've pulled together the Cochrane reviews that we have on add-ons, and I think there's 12 in there. And there's also a good practice recommendation from ESHRA, which many of you will be aware of, that was published in 2023, that reviewed the evidence base for 27 different add-ons, and they relied a lot on the Cochrane reviews where we had them. And only in 5 instances were they able to make some level of recommendation that the add-ons could be used. And they're bullet pointed here at the bottom of the slide. And sometimes these are accompanied by sort of specific circumstances where the add-on use might be recommended, like using artificial oocyte activation only in cases of complete activation failure. And also embryo glue had made it onto that list. And because today we're talking about the patient perspective, or trying to have conversations with the patients, giving patients information, many of you will also be aware of the HFEA traffic light system, which aims to kind of try and translate information about scientific studies on these add-ons for patients. And so the HFEA, who's a regulator of IVF in the United Kingdom, came up with this traffic light system where they label add-ons as either, or when they first introduced the system, there was just a sort of classic traffic light colors of green, orange, and red. And it's since been expanded in the last maybe year or 2 to include these 2 additional fields of grey and black. So if there's evidence that an add-on can increase the chance of pregnancy or live birth, they'll label it green. If there's conflicting evidence, so maybe some studies look positive and some studies look negative or neutral, they'll label it amber or orange. If there's just not enough good evidence and they kind of can't say one way or another, they'll give it a grey question mark. If we do have enough evidence and the evidence suggests there is no effect, doesn't seem to make a difference, they'll label it black. And if there's potential safety concerns, or if the add-on appears to reduce the chance of clinical pregnancy or live birth, then they'll label it red. And this is a snip from their website at the moment. So they've got 13 add-ons covered, and you can see there's sort of a smattering of colours, but notably no green. And so back in 2021, when we were conducting a study we called the value study, we wanted to know what people thought about this traffic light system. So what did IVF doctors and embryologists and also patients think about this traffic light system? Were they using it to inform their practice? Did they trust the information? Did they think it made sense? And that's why we conducted this study. And when we set out to do the study, they were still using the old traffic light system that just had the 3 colours. So this is the paper from that reports the results of that study. And overall, we found quite widespread support for the purpose of the website, or the rationale for the website. So people thought it was good that the website was based on evidence, because a lot of resources out there often aren't. People also liked that because it had come from the regulator, which was funded by the UK government, that it had an independence and that they viewed that as trustworthy. They also liked that the traffic light system was simple, and so it gave kind of a quick answer. And the traffic light, the way they use the traffic light system, they only focused on really the outcome of live birth. So was there evidence the add-on could increase the chance of live birth when they were signing the labels. And so people agreed, well, live birth is the most important. But there was also a number of limitations raised, and we conducted this study because we had an interest in trying to develop something new and hopefully better from here in Australia. And so we really wanted to understand what people didn't like or what they viewed as limitations of that traffic light system, so we could try and overcome those when we were building our product here. I'm just going to go through some of those now. And I have quotes along the way to, because this was a qualitative study, to sort of illustrate the point. So when you see an orange speech bubble, that's a quote from a professional, so either an IVF doctor or an embryologist. And when you see a blue speech bubble, that's a quote from a patient. So one limitation was that people thought the system was overly simplistic. So although on one hand they did like the simplicity of like the quick answer, they also recognise that it doesn't work to just use a traffic light system in lots of cases. It lacks nuance that's actually necessary for the patient to understand the potential pros and cons. So here we have a professional saying, you know, you probably need more shades of orange in a way. And there was a lot of talk about, you know, it's if something's effective and it falls into the green category, and that doesn't happen, or it hasn't happened at all, and something needs to be proven not effective or harmful to fall into the red category. And so lots of things are kind of falling into this middle ground of the orange, and people thought we needed more granularity there. Is it like orange, it's almost green, or orange, it's almost red? And we also have a quote at the bottom of the screen there from a clinician who says, you know, PGTA is so much more complex. You can't reduce PGTA to that, just giving it a red icon. It's not telling the whole story. It's just serving our patients who need more information. Second limitation was the lack of detail. So they just gave the traffic light color and maybe a little bit of text to provide some context, but there wasn't much information about how, what studies were involved, who were involved, who was recruited into those studies, what types of patients, how many people, and how did that information translate into the traffic light color selected. So here we have a patient saying, we weren't given statistics. It didn't really give us much information as I'd hoped for. Tables with the patient ages and success rates overall per age bracket. So they really wanted to see numbers and information provided by subgroup, so they could sort of be reassured by the traffic light color. There was also a lot of talk about the fact that there was just one color assigned to the add-on, and sometimes, I mean, most of the time these add-ons are kind of suggested in specific circumstances. And so it seemed unfair that there was no representation of how the add-on performed in the subgroups that maybe it was people considered that it might work for. And here we have a professional saying, you know, maybe for some sets of patients, those amber ones may improve the chance. But by combining all the studies together and saying, well, does it work overall? We don't get a chance to look at that. There was a lot of comment about the scope of the website. So at the time we did this study, there were 12 add-ons and there's now 13. But because the HFEA is a regulator, they're sort of only interested in treatment options that fall under their regulatory remit. And so they don't cover things like acupuncture or things that happen outside of the clinic or the lab. But from the patient's perspective, they're coming looking for information about, you know, the treatment options they're considering, and they want to see it all. So here we have a patient saying, I mean, surely they know acupuncture is an add-on for people. There was a bit of confusion about the use of the red traffic light color. At the time we did this study, when there was only 3 options, the red was used in 3 circumstances. So if there was possible side effects or harm, if the add-on reduced the chance of pregnancy or live birth, or if the add-on appeared to have no effect. In all cases, it was rated red. And patients or people often think of red as like a danger signal, an alarm, like stop. And so A lot of patients kind of intuition was telling them that red indicated this is really dangerous to do. And here a patient says, my initial reaction was that it means it's unsafe and not to do it. But actually reading into it, it's about the live birth rate, not the safetyness of it. There was a lot of conversation and speculation and perspectives on the fact that there was no green add-ons. And so we have a couple of comments here. So the first is a patient from Australia, because we had Australian and British patients and professionals taking part in this interview study. And a lot of the Australian patients hadn't seen the traffic light website before. And so they were coming along, having used some of these add-ons, and then being kind of presented with evidence that they're labelled orange or red. And for a lot of them, that was quite confronting. So here we have a patient say, I found it a bit confronting. When you look at stuff that you've done and you see that it's red, I was just angry in a way. Why is this even offered? They should have been upfront and said, this is still really in the research phases. And at the bottom, we have a quote that kind of illustrates more of a skepticism about the process, or a lack of belief in what's being presented. And we have a professional saying, I find it really hard to believe that patients that don't have PGTA have a higher chance of getting a live birth than patients that have it. So basically, that they don't agree with what's being presented on the screen. And a kind of related theme was that because the HFEA is a regulator, that they might be more prone to taking a very sort of tough position and setting a very high bar for what add-ons need to jump over before they might be considered, applicable to practice. And here we have a professional kind of, mocking the HFEA a little bit, saying, we are deeply suspicious about each and every treatment that comes up, and we do not classify anything as green. Although people were, thought the fact that it was a government-backed website was a good thing, they also thought that there was a bit of lack of transparency about exactly who was involved in the decision-making process and how they managed to go from the evidence to the traffic light rating. There was no kind of explanation available on the website. And I think especially a lot of the professionals, we all know other professionals who have sort of views about the different add-ons and how they interpret the evidence. So there was kind of a lot of questioning about like who was sitting on that panel when they decided to make those decisions. And here we have a professional saying, it's not as transparent, like who is making the decision on whether there's enough randomized evidence out there. And lastly, I mentioned the focus on live birth. So even though people agreed, yes, that is the most important, it can't be the only thing that we look at. And there are some add-ons that don't even really try and improve the live birth rate. So that's unfair. PGTA being one of those. And here we have a clinician kind of illustrating a different possible benefit of PGTA, saying, if you're taking a couple who had repeated implantation failure and you end up finding out with PGS that they're making abnormal embryos, then I'm sorry, but you're preventing them from having to go through repeated cycles with abnormal embryos. So as I mentioned, we're planning to develop our own, we have developed our own website based in our team here in Australia. So we've taken everything that we learned from that qualitative study and a few other related studies about how people interpret information in the traffic light system and what their information needs are. And we've combined that with input from our expert team. So in our team, we have experts in risk communication, evidence synthesis, decision aids, evidence-informed decision-making. And we used all that to build sort of a draft website prototype. And then we took that prototype through some rather lengthy feedback and modification sessions with both IVF patients and the professionals. And we kept going like iteratively through multiple cycles until, as best as possible, we could satisfy all stakeholders. And then on top of that, we have overlaid our systematic review methodology. So we've got 8 expert methodologists from around the world who are helping us to review the evidence, leaning on Cochrane reviews and other reviews where they're available, so we can add the evidence into the prototype that we've created and turn that into a website. And so I've really tried to approach this using a co-design model, which I'm sure many of you are aware of or heard of, where there's kind of this sense of research now being like nothing about us without us. So all the research should involve the end user, the key stakeholders kind of from the beginning, and make sure you're building something that they actually want, and not just something that we think as researchers looks good or should work. So unfortunately, we haven't launched the website yet. We're planning to launch it at the end of March, but I've just got a little sneak peek to show you. So this is the homepage of the website, and it will be available on the University of Melbourne URL domain. And so on the homepage, we list all of the add-ons. I've just got 2 here, corticosteroids and intralipid, and provide kind of a snapshot of the evidence for 3 outcomes: live birth, pregnancy, and miscarriage. I give a little brief kind of explanation of what the term is, because often patients didn't understand, you know, what's hyaluronic acid embryo transfer media, what types of IVF cohort may the add-on be relevant for, what are the synonyms or other words people might have heard of instead, and then some symbols to indicate what is this? Is this a medication or a surgery? How much am I going to have to pay for this? And is there any possible risk associated with it? So this this field is activated here because there are some quite serious side effects from corticosteroids. So then you could click into it for more information, and another screen would pop up where we give more information about some background, like what are corticosteroids or whatever the add-on is, why might they work, what's the theory, why might they not work, who are they for, and then we jump into the evidence. So when we get down to the evidence, there's tables for each outcome. And so for the outcome of live birth, we say there's no effect. This is based on 2 randomized trials with a total of 814 people. And the evidence is of moderate quality. And then if you want a bit more information, in some cases we have subgroup data. So you could click on, give me the results by subgroup, and then see, okay, well, in repeated implantation failure, there's 1 trial, and it looks like there's no effect. In women with high levels of natural killer cells, it's unclear because we have no trials. And same in cases of women with markers of autoimmune conditions. Because we know that a lot of these sort of immune therapies are often recommended when patients have high levels of natural killer cells. So we want to show people that there is no evidence specifically about corticosteroids in that population, so people can see that. And also we have if you click on here, view trial data, it opens up another box and it will list all the studies involved. Here we only have 2. You can see the 2 studies contributing here and click on those, and it will take you off to the PubMed link for the people who are really interested in reading the original article. So we're launching the website at the end of the month, and this will be the URL. So, you know, it's freely available everywhere in the world, and we're going to cover 10 add-ons at the launch and then build up in scope over time. Really happy for everyone to use it. And of course, if you've got feedback or suggestions, visit the website and there'll be a contact us button, and we're happy to hear them. Thanks very much.
Great presentation, Dr. Lensen. Really informative. I think it's an absolute stroke of genius to include the perspective of professionals as well. And I'd love if you could share if you had any more, you know, general perceptions on what the healthcare professionals sort of, was there one add-on they particularly agreed on? Was there one add-on they particularly disagreed on? And just give a bit further insight into that kind of side of things.
Yeah, sure. So when I put up the little picture, I'll just jump back to it. Yeah. So we involved, so we have IVF patients and professionals in our team, and they've all been involved in kind of trying to help us build like what the website's going to look like, what we're going to cover, the level of detail we're going to go into. And that was sort of confined to that process. And then we had a separate process where we reviewed the evidence. And during that process, we've been very, I guess, careful about managing conflicts of interest, because there's a lot of commercial interest in this space, as we all know. And so our expert methodologists that I mentioned, they're responsible for doing the evidence synthesis. So they're responsible for screening for studies, determining whether a study is eligible, conducting integrity assessments and risk of bias assessments, calling the studies in a meta-analysis, and then translating that into saying this works or this doesn't work. So we've been careful that that group is restricted to only people without any financial kind of conflicts in this space. So I guess to answer your question, there's a lot of different viewpoints from the specialists, like across the whole spectrum, and the professionals about the HFEA traffic light system and what they wanted. I think you're always going to get that with qualitative research. There's always people at the extremes. But I hope we've kind of generated something that everyone's happy with enough. If that makes sense. Yeah.
Tricky position to be in. So on to our next speaker, Madison Bailey, who is possibly one of the best trainees I've ever had. Just don't tell her that. She's working towards her HCPC registration and is based with me at Avenues in London, the first clinic to use a full end-to-end AI-driven infrastructure that captures the most comprehensive fertility data set. She graduated with a first-class degree in biomedical science and was recognized with several awards, obtaining the highest results across her cohort, as well as in her MSc, which is where I met her and lectured her on. She had the top score in that. So over to you, Maddie, on Breaking Bad News, the trainee's perspective.
Thank you, Andrew, for the introduction. So, as mentioned, my name is Madison and I'm a trainee embryologist, just over a year into completing my training via the SCP equivalence route at Avenues in London. And it's a pleasure to have been invited to present at this evening's I3 session on mastering patient conversations in IVF, discussing the process of breaking bad news from a trainee's perspective. So I have no conflicts of interest to disclose other than I'm a full-time employed member of staff at Avenues. So as embryologists, we are often at the forefront of giving news that can significantly impact our patients' emotional and physical well-being. Within the environment of a fertility clinic, it's clear that other teams may not appreciate the vast range of bad news that we have to give within our role. So some examples of scenarios in which we would have to give bad news include abnormal pre-implantation genetic testing results, where at the end of a cycle with multiple embryos, patients may be left with the devastating news that they have non-suitable for transfer. On cycle day 0, we may have reduced egg maturity upon stripping, meaning we have to tell the patient we have a dramatic reduction in the number of eggs available for treatment. On cycle day 1, we may have instances where we have to inform patients that we have failed fertilization and that their cycle has come to an end at that point, as opposed to the experience they will have been expecting, which would have been embryo culture over a period of 7 days. At the end of a cycle, we may have the conversation of poor embryo quality or even no embryos to freeze, and have to make the judgment of poor egg or sperm quality as a source of what we are seeing, which can be particularly hard to hear as an individual. And in the event of a frozen embryo transfer or thawing for biopsy, it may be that we have to tell a patient that their embryo has not survived the thaw, which can be incredibly difficult. We also have the responsibility of informing patients where parameters in their semen analysis are suboptimal or even azoospermic, where there is no sperm present in the sample. And this can be an extremely difficult conversation, explaining their next steps and potential avenues for treatment. So entering the field of embryology just over a year ago, I did not truly understand that one of the most challenging aspects of our role would be breaking and managing bad news. For those experiencing infertility, there's often an invisible trauma that comes with physical, emotional, and financial implications. And we know that the way bad news is broken to patients is what stays with them in the future. So looking at statistics from the Fertility Network UK describe that 40% of patients experience suicidal feelings at some point across their fertility journey, while 47% experience some level of depression, often or all of the time. 59% reported some level of impact in their relationship as a result of fertility care, where 36% of patients reported damage to their career, with a large proportion reducing their hours or leaving their jobs. We also know that these feelings may be exacerbated by the lack of empathy or unsupportive responses from clinic staff, highlighting where it's critical that not only embryologists, but every staff member working in a fertility clinic across disciplines should be effectively trained in managing bad news. And it's our duty as healthcare professionals to manage bad news effectively and sensitively. So from my perspective as a trainee embryologist, breaking bad news has inevitably been challenging. While we as embryologists have extensive technical training, we often lack formal, structured education in handling the emotional side of patient interactions. As a result, many embryologists may find themselves unprepared for the emotional complexity that comes with breaking bad news and the right way to say things due to the fact that there's no standardized approach. So over the last year, some things I've worried about when giving bad news involves how will the patient respond? We know that everyone deals with bad news in different ways. Some may respond with anger, denial, upset. Before the patient picks up the call, you can't prepare for their reaction and how you will consequently deal with that. Patients come from different nationalities, culture, backgrounds, and will, as a consequence, react differently. With experience, I've been told that it becomes easier to judge these different reactions with the ability to adapt and respond appropriately. There are also feelings of accountability and the difficulty that you cannot resolve the problem or outcome for the patient. There's also the balance of being honest, conveying the information not only sensitively, but correctly. So there's no confusion or misinformation for the patient. The pressure to balance honesty with empathy can be overwhelming, and we want to give patients the full picture, but also want to protect them from any additional and unnecessary emotional distress. And a main issue I've encountered is the worry of not being able to answer the why questions. Why has this happened? Why has this been our outcome at the end of our cycle? With this aspect, it's equally as important to acknowledge the scope of your knowledge, especially as a trainee embryologist, to ensure that patients are being given correct and non-conflicting information. Ultimately, as embryologists, our role in delivering difficult news is not just about providing scientific information. It's about helping our patients process, understand, and cope with the emotions that come with fertility treatment. While we can't predict every response or outcome, learning how to communicate in a way that is clear and compassionate is critical. So over the last year, I've developed skills in breaking bad news in various ways. So the main way in which I've done this is by shadowing my senior colleagues, completing a range of bad news calls, seeing how they deal with various situations in context to varied degrees of bad news. So from this, I've picked up on phrases to use and how they structure the call to ensure the patients feel fully supported. And a large component of training as an embryologist, either through the scientist training programme or through SDP equivalents, which is the route I'm taking at the moment, is reflective practice. And this is outlined largely in the good practice guidelines set out by the Academy for Healthcare Science. As such, I use each phone call as a learning opportunity, reviewing the call and outlining what went well and what I can implement in future calls, allowing for that continual development. I also had the amazing opportunity to complete the ARC's Breaking Bad News course back in November, which really covered the fundamentals of breaking bad news from professionals in the counselling field. This course gave me a unique perspective on how to approach these conversations, not just from a clinical standpoint, but also from an emotional and psychological perspective. By providing news in a respectful, empathetic manner, patients are able to better process the information and feel supported moving forward, which ultimately contributes to better long-term outcomes. The ARCS course highlighted core principles of healthcare ethics, a framework for giving bad news, various case studies, which was useful to hear from different perspectives from different trainees and trained embryologists from different clinics, and also components of effective communication. And the course also covered self-awareness and highlighted the strain that giving bad news on a daily basis may have on us as embryologists and how to manage this professionally. When it comes to breaking bad news, in my perspective, preparation is absolutely key. Delivering difficult news, whether over the phone, in person, or in writing, requires a strategic approach to ensure that the message is communicated effectively and with empathy. However, giving bad news over the phone presents its own unique challenges that requires careful planning and ensuring you have all available information in front of you prior to calling around what they already know and what they're expecting to hear. I've learned that you should ensure you are completely uninterrupted during this time, as patients will be able to sense when you're distracted and not giving them your full attention, which can, as a consequence, impact the way that they take in bad news that you're explaining to them. It's difficult to both gauge the patient's emotional state and convey empathy over the phone. Unlike in-person interactions where you can observe body language, tone, and facial expressions, phone calls limit you to vocal cues only. So this makes it important to prepare for the conversation ahead of time to ensure that you can provide the necessary support and clarity. On the call, it's important in any circumstance to ask if this is a good time for the patient to take your call. Asking if it's a good time to talk can have significant impact on how the patient may take in the information and ensure that they're in a safe space. It additionally might be helpful to ask if they have support during the call and are in a comfortable environment, having their partner, family member, or friend there with them. And it's also helpful if you have a pre-developed relationship with the patient, trying to get the same person to call, but inevitably this is not always possible due to staff absence or clinical responsibilities. So establishing a relationship and ensuring that the patient is in the right mindset to receive bad news is a crucial part of the process, especially when delivering sensitive information over the phone. I always start by introducing myself to make the patient feel comfortable. Verifying the patient's information is also critical before giving any news to ensure that you're speaking with the right person. Basic communication has 3 components: verbal, non-verbal, and paraverbal. 10% of a message is given by the verbal component, highlighting how important establishing the correct tone, pitch, and volume of your voice is when providing bad news. It may be tempting to explain information in a scientific, complex way, given your background. However, the use of acronyms and complex information may only confuse the patient and cause lack of clarity. I found it really useful to also provide a written summary to the patient after the conversation, and this has been requested a lot in my year's experience. This ensures there's no loss of clarity and helps the patient to digest the information in their own time. Due to the fact that often the theoretical knowledge underpinning Y cycle may not have been successful will be complex, it may be helpful to ask if there's any information they would like repeating, making sure they fully understand what you are telling them. While it's important to invite questions, some patients may just not be ready to ask those questions and may need time to understand what they've been told, and this should also be respected. The most important thing is to ensure they leave the call with next steps in place. When patients receive bad news, they often feel overwhelmed and are unsure of what the next steps are. By providing those clear next steps, you give them a roadmap for moving forward, and this helps to reduce any confusion and gives them a focus, making the situation feel more manageable. So as previously mentioned, acknowledging that people from different nationalities have different reactions is important when delivering bad news or interacting with patients from diverse cultural backgrounds. Cultural differences can influence how people perceive and respond to difficult information. By recognising and adapting to cultural differences, you can provide a more empathetic and culturally sensitive approach when delivering bad news. Acknowledging those differences helps you to approach the situation with sensitivity and respect, and paired with an active listening approach can ensure the patient is felt appropriately supported and respected. So on ending the call or giving bad news, it's important to ensure they feel supported, while also giving patients time to digest the information that you've told them. It may be useful to ask if they would like a call back later on in the day, if they're struggling to think or ask any questions, or they would like some time to think about what they would like the next step in their journey to be. Additionally, some patients may find it difficult to repeat what you've told them to their partner. If they weren't originally present for the call, it may sometimes be valuable to ask if they would like you to call their partner to save them having to relive the news that you've just told them. In all cases, patients should have readily available access to your designated counsellor to ensure they have that extra support available if needed. A critical component while giving bad news is to ensure that you are actively listening to the patient. In that moment, the patient requires all your attention with no distractions. Although by giving bad news over the phone, the patient will not be able to see if you're doing other things, they'll be able to tell in a way that you're responding to them, and even though they can't pick up on your body language. It's also helpful to give cues to show the patient that you are listening, acknowledging what they're saying, however, at the same time, not interrupting them, as this can be frustrating for the patient. It also helps to acknowledge how they're feeling more directly, especially when giving news over the phone, and as they cannot see the empathy you're showing with your facial expressions. And also allowing for silence rather than continually adding information. It may also help to ask periodically if they're ready to hear more information, as often it is complex information that we're giving to patients, and they may need a moment to digest what we are telling them. So to summarise what I've learned over the last year as a trainee embryologist, the best way I've found learning to manage bad news is by listening to my senior colleagues. From this, I've picked up structure and certain phrases to make giving and managing bad news in a more systematic way. It's critical to always end the call with next steps outlined, giving patients direction and something to focus on ahead. This may be in the form of a follow-up appointment with their clinician or discussing alternative options for future cycles. Over the last year, I've acknowledged that every patient is different and every patient is entitled to deal with bad news in their own way. As embryologists, we have to learn to deal with the various reactions we may be met with following giving bad news, and I'm sure I will develop all these skills more and more with more experience. And lastly, outlining the call ahead of time has been an essential to ensure I have all available information in front of me to support answering any questions the patient may have. Thank you for listening.
Madison, thank you so much for that eloquent and insightful talk. I'm sure everyone learned an awful lot from it. I have a quick question for you. We've heard a few times tonight about Avenues, the program that you're practicing at, being very, should we say, forward-thinking or sort of eager to engage AI and digitalization.
Yeah.
I work in a company that's also kind of promoting AI, and one of the fears that I hear a lot is that fertility care is becoming less personal with AI. Do you think have you got an insight on that or a comment, and particularly how digitalization and increasing amount of digitalization which is happening in clinics could be a source of concern for how we deliver bad news to patients?
Yeah, definitely. I think that's a really important point, as it's very prevalent in the IVF world at the moment, and especially working at Avenues where we are driving innovation with AI digitization. I think we complement the digitization that we see at Avenues with also optimizing patient care. We have lots and lots of patient contact. We still call patients regularly throughout their cycle. We see patients when they come into the clinic. So I think at this moment in time, we're using digitization to supplement our success within the lab. And I don't think that's currently taking away from the sort of patient contact that we get and supporting patients throughout their journey.
Well, thank you very much, Madison. Now it's time for our next talk, which will be by Dr. Lize Leunens. She's an experienced clinical psychologist and systemic psychotherapist working at Brussels IVF, the Centre for Reproductive Medicine at UZ Brussels. She's responsible for the screening and counselling of fertility patients with specific focus and special interest on single mothers, donor conception, surrogacy, and co-parenting. Lize, over to you.
So thank you, all of you, for inviting me to talk about how future generations of adolescents might maybe consider more and more multi-parenthood, and how this paradigm shift will eventually also change our counseling. Now, I don't have any conflict of interest for the content of this presentation, and I do not have any interest in any conflict either. From my work at the fertility clinic of the Brussels IVF University Hospital Fertility Center, I would like to present to you today, starting by elaborating the contributing factors leading to increasing popularity of co-parenting and multi-parenting. So firstly, I would see the evolution from monogamy to consensual non-monogamy as a factor. Secondly, the rainbow families. And thirdly, some threatening aspects of the current practices of donor conception. And so in my talk, I will argue that these factors explain why future generations of adolescents might choose more co-parenthood constellations. Then I will also give you a brief overview on what we already know from the literature about co-parenting and multi-parenting, and we'll zoom in on how we developed our procedures for counseling co- and multi-parenting at Brussels IVF, and I'll give you some key insights from these experiences in this care path. And finally, I will end with some critical reflections, of course. So let's dive into the first argument of why multi-parenthood is likely to become more popular in years to come. And that is, in my view, the increasing prevalence of other relational models, namely consensual non-monogamy or polyamory. So let's start with some definitions first. So as you can see here on this slide, monogamy is defined as a breeding strategy in which two animals mate only with each other during a given period of time. Now, although there are several hypotheses of why monogamy seemed to have emerged as a salvage strategy in the evolution of the human species, several theories of human development and intimacy assume there seems to be a universal preference for monogamous relationships. And indeed, many people can be very happy in monogamous and long-term relationships. Their relationships feel fulfilled and meaningful, but for other people, long-term relationships can feel stifling because of the impossible expectations we force onto our romantic partners. And these expectations can kill our sex lives, ruin our romance, and also eventually lead to infidelity. And that's why the Belgian-American psychologist Esther Perel posits that it's crucial for us to abandon these expectations, be realistic about what our partner can offer us, and rekindle the mystery in our relationship. It's also important to remember that monogamy is not the default state for everyone. It's some people are pansexual or also happy to never settle down with one partner. And so for an increasing number of people, the traditional or classical marriage model is nothing but a social construct and can be perceived as a prison built for two. And indeed, nowadays, a lot of marriages today don't last till death do us part. It is assumed that 2 out of 3 marriages end in divorce. And this means that the majority of adolescents have experienced a separation or a breakup of their parents. And potentially this could have an effect on how they view themselves, relationships as being transient, temporary, but also on the way they're able to form stable attachment relationships as adults, or are more inclined to either not attach or need more than just one person to attach. So why only commit to one single person to love? And does love really have limits? And that brings me to the definition of what polyamory is. And as you can see in this slide, it is the practice of or the desire for a romantic relationship or relationships with more than one partner at the same time, with the informed consent of all partners involved. And so in 1997, Janet Hardy and Dossie Easton caused quite a stir, issuing their book, The Ethical Slut. And this book describes how to live a life with multiple simultaneous sexual relationships in an open and honest way. The book also includes chapters on how consensual non-monogamy is handled in different subcultures, such as among gays and lesbians, information on dealing with scheduling, jealousy, communication, conflict in relationships, and etiquette for group sex. And as you can see, this is a bestseller. Also, polyamorous relationships are more and more openly depicted in popular media, films, and series. As in the film Professor Marston and the Wonder Women, a 2017 American biographical drama film about the American psychologist William Moulton Marston, who created the fictional character Wonder Woman. And in the year 1928, William and his wife Elizabeth teach and work at Harvard and Radcliffe colleges. And after hiring one of his students, Olive Byrne, as a research assistant who aids in inventing the lie detector device, the three soon grow close. And one after another, tests with the lie detector reveal that they have fallen in love with each other, and all three of them begin to engage in a polyamorous relationship. And as the word about their unconventional relationship gets out, the Marstons are fired from the university. And eventually, Olive reveals that she's pregnant. She moves in with the Marstons shortly, and the trio decides to build a family together and create a fabrication to keep secret the nature of their relationship. But how popular is non-monogamy really nowadays? So you see here a slide from YouGov, and YouGov is a British international internet-based market research and data analysis agency. And in 2020, they conducted an online poll amongst American citizens and found that although overall 56% of Americans still see monogamy as an ideal, there seems to be a shift in generations, where you can see that for millennials, they are more likely than people from Gen X, and even more than baby boomers to view non-monogamy as ideal. And in their survey, also 1 in 4 US adults are actually in non-monogamous relationships, with the highest occurrence again in the millennial population. Now, in 2023, they reiterated the poll, indicating men and women under 45 are more likely than their older counterparts to be interested in something other than complete monogamy, like you can see here. Although 18 to 44-year-old women still are slightly more likely to prefer complete monogamy, here the 46%, to either complete non-monogamy and or something between the most polarized options. Now, the present research that you can see in this slide is conducted by Amy Morse and her colleagues from Chapman University and the Kinsey Institute, and they draw on a United States census-based quota sample of nearly 3,500 single adults to estimate the prevalence of desire for, familiarity with, and engagement in polyamory. And these results are much less impressive than the previous poll results, but still show that 1 out of 6 people seem to be desiring to engage into a polyamorous relationship. 1 out of 9 people have actually engaged in polyamory at some point during their life, and approximately 1 out of 15 people reported that they knew someone who has been or is currently engaged in polyamory. And in her study, sexual minorities, men and younger adults reported greater desire to engage in polyamory compared to heterosexuals, women, and other adults, respectively. Men and people with lower educational levels were more likely to have previously engaged in polyamory, and few sociodemographic correlates emerged. So no difference in prevalence were found based on political affiliation, income, religion, etc., etc. So in conclusion, from this first point, non-monogamy seems to be an increasing trend in relationship ideals among younger adults. So coming to my second factor leading to the increasing popularity of co-parenting or multi-parenting are the rainbow families. And the term rainbow family refers to a family with parents of the same sex bringing up a child, or an LGBTQ plus parented family. And rainbow families, of course, like all families, come in all shapes and sizes. A great number of them are created through the use of donor gametes, of course, or even gestational surrogates. And these families break the traditional image of a heterosexual two-parent family and can consist of more than two parents or carers. And then coming to a third factor leading to the increasing popularity of co-parenting are specific threats or negative aspects associated with donor conception. So first of all, as you all know, nowadays the demand for donor gametes largely exceeds the supply. And this leads, of course, to sometimes long waiting lists in the clinics to provide patients with donor gametes. And in the case of donor oocytes, this waiting time may even go up to several years. The increased need for donor gametes is then, of course, partly due to the postponement of parenthood, which has become a defining trend for infertility in the more developed countries over the past 4 decades. It has been driven by a number of interrelated forces, of course, including greater access to and longer pursuit of education, gender revolution, changes in partnership formation and dissolution, and by growing economic uncertainty among young adults. Another threat to the survival of donor conception is the donor anonymity, which is still enshrined in the law of a number of countries. And at this time, in Belgium, for instance, fertility clinics are still legally obliged to make all the information about the donor inaccessible without any exceptions. And this is, of course, problematic for various reasons. So within the current system of the donor anonymity, children's rights to have access to their origins are subordinated to the needs of the parents or the rights of the donors. And it needs to be said that also an increasing number of intended parents themselves no longer accept donor anonymity and would like their child to have the option of being able to identify his or her donor. The rights and interests of donor-conceived persons have been recognized with the Council of Europe, recommending the member states back in 2019 to abolish the use of anonymously donated gametes. And so international and European human rights law, including the United Nations Conventions on the Rights of the Child and the case law of the European Court of Human Rights, has in the last decades moved towards recognition of a right to know one's origins, connected to the right to an identity and to personal development. And this right includes the right to access information that will make it possible to trace one's roots, to know the circumstances of one's birth, and to have access to certainty of parental filiation. And these developments might lead prospective parents to turn to unregulated online sperm donation. And as you can see, indeed, there is a rise of internet websites dedicated to facilitating contact between individuals who want to meet people with the common aim of having a child. And such websites have made elective co-parenting accessible to large numbers of people, including both single and those with partners. And furthermore, these websites are not restricted to LGBTQ plus individuals, so heterosexual men and women can also become members and contact potential reproductive partners who may be of a different sexual orientation to themselves. Now, to date, there has been limited research investigating women's motivations and experiences of searching for a sperm donor online. Vasanthi Jadva and her team, they undertook an online survey study on women looking for a sperm donor on Pride Angel, and this is a website or one of the websites facilitating contact between donors and recipients. And so the most common advantage reported was being able to connect and to meet with a donor. Francesca Taylor and her colleagues argue that the restrictive UK policies and practices for regulated clinical donor insemination are a potential explanation for the growing use of the currently unregulated online route to donor insemination. And Guido Pennings performed a SWOT analysis of unregulated sperm donation, indicating that the most important strength of the informal system is the demedicalization of sperm donation, and thus the increase of women's reproductive autonomy, whereas the main weakness seems to be the possibility of abuse and morally questionable behavior on the part of donors. And somehow the line between donor and parent becomes difficult and vague, and certainly with the so-called internet donor who does not sign any contracts and is not legally protected. So maybe co-parenting and multi-parenting will not only become more popular, but maybe these family models are the solutions for future generations. But what exactly do we already know about co-parenting? So literature shows that co-parenting or co-parents are mostly motivated to seek such arrangements in order to create a family that is in line with their values with regards to family building. And indeed, co-parenting offers the possibility to overcome uncertainties linked to other reproductive options such as donor anonymity, single motherhood, surrogacy. Co-parents apparently choose this option in order for their child to have two biological parents, a mother and a father, who are both involved in the child's upbringing, and for them to know the child's background. And co-parenting gives the opportunity to have biological descent, to experience pregnancy for women, and to provide the child with a mother and a father. And this reflects a traditional significance placed on genetic relatedness as defining parenthood, as well as on the two opposite sex parent family model. Furthermore, co-parenting allows to better balance professional and family life, and therefore it seems that this way of family building is on the rise in heterosexual men and women. And what seems paramount in this way of family building, and this is really mediated by the fact that such multi-parenting arrangements cannot validly establish the rights and duties of non-legal parents, is the need for negotiation. So co-parents need to negotiate, create, and legitimate the role each of them will play in the child's life. And these roles and responsibilities should be then acknowledged by every parent, by the child, as well as by the wider social network. And co-parents also need to agree on the very practical things regarding daily upbringing, like childcare, time allocated to all parents, etc. So let's now zoom in on how we developed our procedures for counseling co- and multi-parenting at our own fertility center. We initially defined co-parenting as a project in which two or more people, regardless of their gender, intend to conceive a child together with their own gametes and to be the parent of it, each with parental rights and duties, and in doing so, not having an amorous union nor intentions with each other. So in designing this co-parenting procedure, we defined some inclusion and exclusion criteria, and some of them are, of course, completely in line with our other intake criteria for heterosexual and homosexual couples, like, for instance, professional and economical stability, the age difference. Age limits also were aligned with our internal age limits for other family projects, like single moms by choice, for example. And we initially also thought it would be important that co-parents did not have an amorous relationship throughout the course of the project. Because if they had or started an amorous relationship, then the trajectory would become redundant, and they could try to fulfill the desire for children in maybe a spontaneous way. They also should have had regular and intense contact with each other for at least 6 months, and geographical proximity is also a must. Now, welfare of the child is the guiding principle leading to a joint parenting project worked out together with all the co-parents. And in addition to the inclusion criteria, we also developed a clinical pathway for co-parenting trajectories in our center. So candidates first submit their requests to our secretaries, and then on the same day, we try to schedule the first appointments, as you can see, with the fertility specialist to start the medical and the fertility checkup, and also with 2 psychologists at the same time who interview the 2 candidates and or their partners. And this leads up to a first team discussion. And in this discussion, we put together all the gathered information and we look at potential red flags or concerns. Then the psychologists who saw the patient submit this case to our ethical reflection cell, and in case of a positive advice, we plan a number of joint consultations with all co-parents in which we further screen and elaborate their co-parenting project. And then once the fertility treatment has started, we also start with the elaboration of a birth plan and a co-parenting plan. And follow-up continues during pregnancy and once the baby is born. Now, during the psychological consultations, a number of topics are addressed with the candidates, as you can see in this slide. And so apart from the screening purposes, these topics are also the ones that will need to be negotiated between the co-parents and will lead to the joint parenting project. And when the fertility treatment has started, we further counsel them into preparing pregnancy and birth. And in our role as psychologists or psychotherapists also, the focus really lies on facilitating communication between the co-parents, allowing them to express their own values and needs, and also negotiating. So we don't think there is just one best way. It is rather a tailor-made approach in which every project should reflect as closely as possible the personal situation of the co-parents. And during this process, we generally raise topics they hadn't thought of before, and we help them designing their arrangements in the long run. And of course, the welfare of the child is our continuous guiding principle. Now, lastly, and I know this is a quite busy slide, I would like to present you a brief overview of our experiences so far. So as you can see, since the beginning of our procedure in 2021, we received 18 co-parenting requests, and all but one had a single heterosexual woman as one co-parent. About 1/3 of the projects had a gay couple as other co-parents. One project was not received to go through because of the young age of the co-parents and the fact that this project was very unclear. This was project number 8, as it consisted of 3 cohabiting lesbian women, and then we would have had to include donor sperm. Now, one project, project 15, was redefined and started treatment as a single mother by choice and a known sperm donor, since the initial male co-parent did not show willingness to take on full parental responsibilities for the child. Another project, project 16, sought our help for their second child, as they already successfully co-parented a first child with which they conceived naturally. Now, about 1/3 of the projects were called off by one or both of the co-parents. Strikingly enough, all in a constellation of a single woman and a single heterosexual man. For example, project 3 was this one here, was called off by the woman herself because she had second thoughts. She didn't feel confident enough about the combo, as she called it, with the co-parent. She couldn't envision herself making a child with him. Project number 9, this one, was called off by the man because he got promotion at work and he didn't see fatherhood as a priority anymore. The woman was then considering treatment as a single mother by choice. Project number 11 ended likewise. The man suddenly felt the incompatibility of parenthood and his work as a self-employed construction worker. Project number 12 ended because of a relational dynamic between the two co-parents. The woman had the impression the man was coming too close and wanted a relationship with her. And he felt she pushed him away. Then one project was granted positive advice. It was project number 2, but they were French, and they eventually found a fertility doctor in France who was willing to help them. And for project number 17, here in the end of the slide, we are currently offering decision-making support for the man, since he made it very clear he was very uncertain about his implication in a parental project altogether. And finally, I can tell you with great joy that 2 babies are born, 2 are on the way, and the co-parents in 4 projects are in treatment. Now, coming to the critical reflections and the lessons learned, I think it's very clear today that the specifically designed co-parenting care pathway is really a way to legitimize these projects and also to provide clarity for the patients. And as these psychological consultations are mandatory to screen, inform, but also counseling all parties involved, and I showed you the specific topics we include. You should also check the informed consents in your own country's legal framework. Will the co-parent be identified as a known donor or as a father? And you should also focus, of course, not only on the desire for a child, but on the future life organization as co-parents. And so the need for aftercare is crucial. I also want to stress that this is really a pioneering population with no societal scripts on how to co-parent. And so these people really themselves are willing to get counseled. So they are really coming to us to receive all these advices. We also see that the geographical proximity seems vital once the baby is born, since these co-parents tend then to really also live in one house to be able to take care of the newborn baby, both of them or with all of them. And then, like I said, the co-parenting is a very intentional project. And through the psychological counseling, the co-parents start their parenthood in a very prepared way. And that's also one of the feedbacks we generally receive, that they never thought that they could access parenthood in this very prepared way. It is a time-consuming procedure. Since it's multidisciplinary, many actors are involved, so it enhances the complexity, of course. We know that little is known on the long term, so it's still unclear on what the impact will be on adults and children that are involved. So the follow-up is necessary. And I would like to end by maybe asking the question again, whether co-parenting would be the solution of the future. Because once we start imagining and then living also in a world of fluid parenting, it becomes increasingly likely that we will also undo or at least revise our centuries-old conviction that procreative unions like Noah's animals only come in pairs. And maybe our species' new ark is composed of a motley crew of threesomes and foursomes, old and young, men and women, and those across the spectrum of gender identity, reproducing with whomever they choose and loving as they desire. And I thank you very much for all of your kind attention.
Thank you, Lize. That's a whirlwind tour of a very, what I'm assuming is going to be a very topical conversation and become more normal and more common over the next couple of years. I see maybe one set of patients a year, not quite in that kind of format, but generally where it's been a couple who have been married and had IVF treatment and had a child, and then they've divorced, and the female partner wants a same full genetic sibling, and the ex-husband essentially acts as a known donor in allowing her to use the embryos. but doesn't really want to engage in the process. He's basically just signing his consent and saying, yeah, do it. I acknowledge I will be the legal father, etc. But trying to get them into the counselling can be implications counselling can be quite challenging. I just wondered how often you sort of, if at all, you see that scenario, and whether they go through the full ethics review that you talked around. Any insight you can share?
Yeah, I think it's a very nice question, Andrew. Thank you so much for that one. I think what strikes me in your question is that as a psychologist, I would stress the importance of clarity, and clarity in the definitions of roles and expectations, and not only for the co-parents or the adults that are involved, but of course for the future child, which should know, of course, well, who desired me, who are my parents, and where do I come from genetically? And so should I address Mr. X as my father, or is he my donor? And what makes him very different regarding me, comparing to my sibling that is already been born? So I would say in that perspective, I would really motivate the future parents to reflect on that aspect. How are you going to explain this constellation to your future child?
Yeah.
Interesting. Lize, if you don't mind, I'll ask a question, and I think we've actually got lots of questions for all the rest of the presenters, so we'll probably move into a general kind of Q&A and pick up on all the questions that have been put through the chat. You mentioned, Lize, that for the co-parenting situation, the kind of co-parents would have need to have known each other for at least 6 months, and the question was surrounded how you arrived at that number. I think some people were saying maybe it feels short. Perhaps some people are saying it feels really long to have known somebody. So you must have landed on that 6 months somehow. How did you arrive there?
Yeah, well, it's a funny question, because of course there is a sense of arbitrariness in it. We generally would like to say, okay, 1 year of relationship or knowing each other, going through all the seasons together, knowing how each of them celebrates Christmas, New Year, holidays, etc., would be very nice. But we also acknowledge, of course, that sometimes a year can be a lot. For instance, for people who get to know each other through these internet based communities, and that's why, as a consensus within our team, we've landed on the 6 months. Period of time, although personally I think it's quite short.
Yeah. Are there instances where you would counsel prospective co-parents that they actually need to maybe spend longer together? There might be like a red flag that you've seen, or once you've set that kind of guideline, do you just tend to stick with it?
Well, that's the relativity of it all also, because you can put a timely measure to it, but indeed, of course, when we have these conversations with all the parties involved, we can see how they communicate with each other, how they and I'm maybe also referring a little bit to Madison's talk, how they break bad news towards each other, how are they engaging in conflict, how do they also spread bad news. I mean, these things we can observe, and we can also ask them, what are your communication styles? So these things are more qualitative information, and that's way richer than only going for the rigid timely measure.
Thank you.
Feeding on to your reference to Maddie, there was a comment, Maddie, from Karen Bell, in which LinkedIn tells me she's from Brisbane, so apologies if it's the wrong Karen Bell. Just a comment about giving bad news to patients. Patients obviously ask why, but many clinicians want to answer this. and actually steer embryologists away from saying something that might conflict with what they might say. And they want to have all the patient information in front of them, and it can be challenging for embryologists. So how do you balance, in terms of that embryologist clinician relationship and giving advice to patients and, having that dialogue, essentially 3 ways?
Yeah, I think as embryologists, we sort of have the responsibility to give patients the facts of what's gone on in the cycle. I think at Avenues we're quite lucky as we have quite a close relationship with all of our clinicians. So we can sort of liaise with them and make sure we're all on the same page. But I agree, I think it's challenging to ensure that patients aren't given misinformation. And I think it is about the balance of ensuring that you're letting patients know sort of indications from their cycle, but not going as far as to say the implications that the clinician might want to discuss with them.
So Madison, on the same topic, we have Tom Howarth. He says, I have had some patients' feedback that they don't like the word collapsed to describe a blasis after thawing. Has anyone found an alternative way to describe this? Any idea how do you describe that in your lab?
Yeah, I think it can be a little bit of a scary term to when you say to a patient, your embryo is collapsed. But I think by explaining sort of the theory that embryos collapse when at the freezing process, and it's a completely normal thing that occurs with embryos once they're thawed, I think just ensuring that the patient is properly educated on why we use that term. I'm unsure if there's a better alternative, but I think explaining it to them technically, I think that's completely fine.
Yeah, so I'm also an embryologist. Sometimes I use the word folds, and it has worked for me. It kind of describes the same thing. Yeah, and then I think Sarah also mentioned something about sometimes it's difficult to discuss the genetic results, especially if you're an embryologist, what is abnormal embryo, or how do you discuss that with a patient over the phone? Would you go like, it's an abnormal embryo, tested one, how do you communicate that with the patient?
I think as a trainee embryologist, I haven't had much experience in sort of explaining genetic results. I don't know if Andrew has a better insight into this.
I mean, I pretty much do exclusively bad news phone calls. We have, historically and in current center, we get, about 1 trainee a year to every 18 months. So we're always training someone. So the trainee, essentially gets to cut their teeth on doing the good news phone calls and then listening to us do the bad news phone calls. So Maddie's not quite there yet in terms of breaking the bad news. But I dare say she's listened to a few. So, it's a very, it just comes with experience, and I think personally, it's not just about the embryology team in terms of making sure the person doing the bad news is okay afterwards, with the nursing team and they have a bad pregnancy scan. If you're high up in the management food chain and you're having to phone patients to tell them something's gone wrong and, you're having to do duty of candor and that kind of things, it's always worth checking in on your teammates just to make sure they're okay after a particularly difficult phone call. But yeah, this is going to sound really sadistic, but it almost becomes kind of enjoyable, because it gives you a break from the same thing, the routine, and it allows you that, that bit more of a in-depth conversation. And I've literally just seen a message pop up. I wasn't going to tell the story, but at one point, someone's texted me to say, make sure you tell them. At one point in a previous job, I did so many bad news phone calls consecutively that they gave me the nickname Andrew, the Crusher of Dreams. Thanks, Heather. So I mean, it just comes with experience and learning and the coping mechanisms that go there too. But I think we should move on to something that's slightly more upbeat, shall we say? Let's talk about add-ons. So, Dr. Lensen, in terms of add-ons, it's almost got this negative kind of connotation with it. It's been, add-ons, private clinics do add-ons, NHS clinics don't. It's almost become essentially a taboo word. Is there another word we can use? Is there another phrase?
Yeah, I agree. I think when we were doing our interviews, we spoke about this, and a lot of the professionals particularly didn't like add-ons, and I think a lot of the media stories that have come out about add-ons have been quite negative. And so it's kind of coloured the term and trivialized it. A lot of people like add-ons, like I'm buying a car and I'm going to get like heated seats put in, it's an add-on, and professionals would say, we're doing complicated health intervention here. We're not like putting, we're not like adding fries to a takeaway order. Kind of people didn't like it for that reason too. So on our website, we've gone with the term optional extras. And I think professionals prefer that, but patients don't mind the term add-on from what they haven't been so exposed to, I guess, like the negative connotations that come with it, and they think it represents the treatment okay. But to try and keep everyone happy, we're using the term optional extras, which is a bit longer, but hopefully more suitable.
Sarah, there was a question that came in around how often the guidelines will be reviewed. Do you have set intervals of time, or is it as and when new data arises?
Yeah, that's a good question. So we're planning to update the evidence at least every year, hopefully every 6 months, because we know, particularly the patients that we spoke to, they have kind of a warped idea about how long things take, and they were like, that's 3 months old, that's so old. So yeah, we're planning to update the evidence every 6 to 12 months as we go. And I think that's one other limitation of the traffic light system. They're moving to a 5-yearly update at the HFEA, which is going to be quite slow. So we're hoping that will be a source of people be able to come to our website and know this is the accurate list of all the relevant clinical trials on this add-on.
Yeah, okay, thank you.
Sarah, I also have a question. So what type of studies you're using? Talk a little bit very briefly on the methodology you're using. How do you evaluate the studies?
Yeah, sure. So we are focusing on randomized controlled trials where the person's been randomized, not the gamete or an embryo. And we're essentially following the Cochrane review process in terms of how we conduct the systematic review portion. So focusing on randomized controlled trials, we perform Cochrane risk of bias assessment and grade assessments to assess the quality of the evidence. And we're also have added in an integrity assessment because we're aware there's a growing kind of concern about many clinical trial results having integrity problems or possibly being fabricated. So we're sort of heightened to the risk of that. And then once we've done the meta-analysis and pulled the studies together, then we have to translate that into the categories we use. So we're not using a traffic light system, but we're using this might increase or possibly increase the chance of the outcome, or it might decrease or possibly decrease the chance of the outcome, or it might have no effect, or it might be unclear. So yeah, essentially we're following the Cochrane methodology.
Thank you.
Yeah, I mean, in terms of how the HFEA work with the traffic light system, I know there's a lot of perceived mystery about how the traffic light system, not that it looks like a traffic light anymore, about how they set it. And actually, it's all on their website. They list the minutes of the meetings. You can read the papers and what they've reviewed in the last meetings. And, you know, it's going on to a longer cycle of years, but you can actually, you know, submit an application to you know, if you think there's been some good evidence come on, you can actually instigate a recommendation for them to review it early. So, you know, at the moment, mitochondrial donation is kind of a hot topic. And it, you know, the HFEA send like a monthly clinic focus, and they had it said in the clinic focus that they had just re-reviewed the evidence for mitochondrial donation and essentially rejected it again for common use or more general use. So I think actually the secrecy, it's perceived, but it's not actually there. You know, it's all very upfront. So
I guess the
moving.
only thing I'd say to that is that patients can't find it. Like all of the reasoning's buried in a very dense SCAC minutes document in scientific language, not intended for like a lay audience. And because the website's changed since we did that study, and now they do have a list of the study, like the DOIs of the studies that they've included. But I think, yeah, none of the patients that we talked to after we sent them to the website to look at it had come across the minutes. So I think it's there if you know where to look, but it's not super accessible.
Yeah, agreed. So moving back to Dr. Leunens, you know, you talked about 17 cases.
18, yes.
18 cases over, you know, a few period of year. What kind of percentage of your, you know, how many cycles are you doing a year?
Wow, it's a difficult question for me because, well, of course, as a psychologist, I don't really tap into this. But annually in our center, we perform around 6,000 cycles of IVF. So when you see these 18 demands for a co-parenting arrangement, that's really it's peanuts.
Yeah. So it kind of, as a proportion, it kind of fits in with my one a year. So yeah.
Oh yes, yeah.
And you know, the regulatory restrictions are obviously going to be different country to country. So yours was obviously specific for Belgium. Are you aware of any other regulatory restrictions in other countries?
Yes, for instance, I can speak about Belgium, but I think that in a lot of countries it will be a bit likewise. In Belgium, you can nowadays only have 2 legal parents. So that means that any extra parent cannot obtain parental rights and responsibilities. And so that's one of the things we would like to highlight in our counseling sessions. Which we raise this awareness because people generally tend to come to us in a very well-intentioned and a very, I should say, positive and a very, sometimes also very romantic view on parenthood, and then of course we should warrant them that of course once you look at it from a legal perspective, only 1 or 2 of them can obtain the legal rights, parental rights over this child. And that's really important. And the Netherlands today or yesterday issued this refraining. They were going to look into changing this, for instance, in the Netherlands, but due to the complexity and the cost that's around these issues, the Dutch government has put it in the freezer again. So even in a country where these things are really, really advanced, even there, these legal changes are slightly put aside. So that's why the legal view on things is really, really crucial, and that pertains to anyone who would like to implement a co-parenting procedure at their own clinics.
Fantastic. Thank you, Lisa. I think we'll have one quick question from Madison, and then there's still so many questions left. We're going to break into a quick fire, and we're going to try and keep it to short answers. So, Madison, one question for you. This is not a quick fire. You can take your time with this one, but I'm giving everyone a heads up so they know what's coming. So, in terms of you spoke a lot about the emotion that's involved in going through IVF, and you know, even if it's good news, that whole process is very, very challenging for patients. I wondered if you could just comment on where you see the role for employers to give compassionate leave for patients who are going through the process to have time away from work, to be able to focus on this journey. Have you seen that happen? You're in London. It's quite a progressive city in terms of employee benefits. And if you haven't, do you have any ideas or thoughts around it?
Yeah, it's not something that I'm sort of aware of at the moment, but I think, like I mentioned, the statistics are there. There's so many people going through fertility treatment that are either reducing their hours at work, losing their jobs, due to the emotional implications that fertility care can have. I'm not sure if anyone else is aware of this. I'm not too sure, but yeah, I think it's an important topic, and hopefully we see more employers implementing it.
Thank you. Okay, Andrew, do you want us to kick us off on some quick fire?
Everyone's favorite add-on. I'll go first. Time lapse. Next.
Acupuncture.
Sorry. Anyone else? Simon?
I'm going to say PGTA.
Oh, devil's advocate. Maddie?
I'm saying PGTA.
When done well, should we say?
We need to do a whole webinar on the pros and cons of PGTA. Elina?
Yeah, what can I say? Yeah, I'll say PGDA.
Lisa?
I have no clue.
All right. Next quick fire question.
Uh,
Anyone?
Liz, I think this one could be for you. It's a question about how internationally recognised is the HFA traffic light system outside of the UK. So some of the other panelists have specifically spoken about it in Australia, but for you, not being in Australia and not being in the UK, not specifically looking at add-ons, have you heard of the HFA traffic light system? Does that have any bearing on how clinics are practicing in Belgium?
I should say, well, again, from my perspective as a psychologist, which is only a very limited perspective, I've heard of it. Yes, I did.
You got a quick fire for us?
Should ICSI be considered an add-on?
I'll take this one, I think. Quick answer, sometimes. When it's not for male factor or for failure, I think, yes.
And PGT, we know you're all a fan of. Do you think the negative publicity with, you know, there's certain high-profile cases going on around the world, the negative publicity with PGT, do you think that will rub off on the other add-ons?
This is a tricky one for a quick fire. I think quick answer, probably not.
I agree. Simon? Any thoughts?
I honestly don't know. But potentially, I think it's perhaps isolated to the US. So maybe it's in the US, you might see a slight drop off on some of the other tests, but
Yeah, I mean, it's not just the US. There's some stuff in Australia as well, and you know, it's worth noting not all PGT labs are the same. Other quick fire questions. Anyone? Who has the responsibility of breaking bad news to patients? Gynecologist, embryologist, nurse, psychologist, or the front desk? I imagine that would go down well.
I think everyone but the front desk. I think everyone's got different responsibilities, and yeah, everyone has to give bad news in different aspects of fertility care. So
there was a great acronym from I3 alumni, Tracy Sainsbury's, who had the acronym PRIDE, which was personal responsibility in delivering excellence. and every member of staff should have pride, particularly when, you know, breaking bad news. So I think that's a good take-home message. And I think probably time to wrap up the session. Time's ticking.
Yeah, we've had a good session, lots of questions being asked, really interesting topics. And I'd like to thank everybody who took part in the webinar, my co-host, Andrew and Elina, and presenters, Dr. Lensen, Madison Bailey, and Dr. Leunens. Thank you very much.
Thanks, Simon. Let's not forget to thank the team from I3, the organising committee of this initiative, who are Jacques Cohen, Peter Naj, Marianne Cervantes, Thomas Elliott, Fran Farley, Violetta Sura, and Giles Palmer.
Okay, and don't forget the next session on green IVF, taking action. And I think that will be next week or the week after.
Thanks all. Bye.
Thanks all. Have a great evening.